So we're almost set up. So in the interest of time, I think I'll start with the introduction. So welcome to our second October Method Seminar. So first off, I hope everyone is safe from all the fires that's happening in Los Angeles. But today we're very fortunate to have Dr. Karen Fortuna. So she's the Assistant Professor of Psychiatry in the Geisel School of Medicine at Dartmouth College. And her primary research interest is in service delivery strategies for older adults with serious mental illness and chronic health conditions. And she's focused on using community-engaged research methods to develop and implement a peer-supported mobile health intervention. So all of us do a lot of work with mHealth strategies, and I'm really excited to spend an hour with Karen to kind of learn more about the work that she's doing. And the title of her talk today is Co-Designing Smartphone Apps with People with Serious Mental Illness to Impact Population Health. And I'm hopeful that after her talk we can engage in more discussions about some of the common work that we are doing. So please welcome Dr. Fortuna.
Thank you so much for the introduction, and thank you for organizing this for me. It's great to be at UCLA. My name is Karen Fortuna. I'm Assistant Professor of Psychiatry at Dartmouth College, and today I'm going to talk about developing and implementing peer-supported digital health interventions for people with serious mental illness. And so, are people familiar with individuals with serious mental illness? Anyone work in that area? Anyone not work in that area? Okay, all right, cool, just so we know. I work with people who have a diagnosis of schizophrenia spectrum disorder, bipolar disorder, and or major depressive disorder. And I hire them to actually provide interventions for me. So they're actually the interventionist, and they provide interventions to other people who have a lived experience of a serious mental illness. And so we call this peer support, and we use the smartphone technology to aid in the delivery of the intervention with fidelity. Because as you can imagine, if potentially people have a lived experience of a serious mental illness, staying on track and providing a fidelity adherent intervention could be potentially a difficult task for individuals. And the hope of this research is really to address the early mortality gap that people with serious mental illness experience. And so people with serious mental illness, they die up to 32 years earlier than the general population. And that is said to be because of health behaviors. They're not dieting, they're not exercising, live a very sedentary lifestyle. And so we're trying to get people to engage in these types of interventions and using peers, so people with a lived experience of a serious mental illness, to help with the engagement process. So if there's any questions as we go through, please just let me know. No disclosures. I do have grant support from the National Institutes of Mental Health and NARSAD Young Investigator Grant. So today I'm going to talk about the law of attrition that is experienced in most digital health applications. And I'm going to talk about user-centered design and how we can advance that and move forward to develop more of a co-design process with individuals, and talk about some really neat future opportunities with this population. So we all know about the ubiquity of smartphone ownership. So everyone in here, of course, has a smartphone. Well, people with serious mental illness, they also own smartphones and use smartphones as well. And so about 80 to 95% of that population has smartphones. And what do they use them for? The same way that we use smartphones. So it could be to access information, talking to friends and family members. And there's been quite a few smartphone apps designed for this group related to providing information, self-management training, or even evidence-based therapy. So there's some cognitive behavioral therapies that are on smartphones as well. So we have this plethora of mental health applications. You have people with serious mental illnesses using these applications, and so what a great opportunity to promote population health. But there's a major challenge with these smartphone apps. You can't just create them and there's uptake and people use them automatically. How many people out there have downloaded an app and then never used it again after they've downloaded it? Right. And if I tell you to use it, is that going to increase your want to use it? It might actually have the opposite effect. So a fundamental challenge in digital health engagement is this law of attrition, which was put forth by Gunther Eisenbach, which is suggesting that we can develop these amazing programs, interventions on our smartphones, but it doesn't mean people are actually going to use them. And so we will see a drop in engagement after the first 2 weeks. So we can spend millions of dollars developing these things, or hundreds of thousands. It doesn't mean people are actually going to use them. And when we do this in research studies and we put these programs out there, there's of course a loss of intervention effect if people aren't using the intervention on the phone. Data integrity, we have a lot of missing data, and how do you handle that? And let's say we make assumptions based on the data that we do have. It could be lead to a misinterpretation of findings due to these missing factors. So what Psychiatry has done, and my colleagues here, they developed this consensus statement about how do we address engagement with these apps, and they came up with every app developer should use user-centered design in developing this. And so these are usability studies, which I'll walk us through, where you're in a very clinical environment. I give you the phone, and I'm going to watch you as you go through it. I'm going to record you. I'm not sure how that would impact you using the phone, but it's just two people in a room like this, a very clinical environment. So can we see what potentially that could maybe not be helpful for population health if we're in this very clinical environment using this smartphone app as I'm standing over you and watching you as the researcher? Any thoughts?
I think it's just very uncomfortable for the person, because a lot of times even when you see people on their phone, it's just like them and the phone, so to have someone else looking over you is uncomfortable.
So it could create a bias if there's another individual there, right? Anything else? Come on.
Well, and I think what you already talked about, the attrition that happens, just because I'm standing over and you watching you right now, that doesn't mean you're going to use it the same way a week from now, 2 weeks from now.
Exactly. So, yeah, exactly. So the context of the individual and their environment is really important. And some user-centered design gets to that, but within the studies developed in or published in Psychiatry, it stays more to these clinical environments and usability testing. And these usability testing, it is said to increase engagement and use, but I don't think it's getting at the real-world experience of the individual. So here's the user. This is what I was trying to replicate here. Sorry if I made you uncomfortable.
Yeah, it's okay.
So very clinical environment using this together with an individual. Now also when we do user-centered design, which is an entire field of study, this is a picture of the Pokemon Go app. Does anyone remember that? Where it was like, it's like augmented reality, and you go out in the world and you can find, I think it's like these Pokemon. I guess that's what it is.
We have a coworker that still does that, so we're very familiar with that.
Okay, everyone. Maybe more familiar than I am. So okay,
Yeah.
good. So anyway, so this was an amazing program, right? And we thought, like, as health researchers, that we can get people out there walking and moving because they're out there chasing these Pokemon, And interesting enough, there was certain places where there wasn't Pokemon, and so this is a picture on this is my Poke Hood. This is a Twitter that somebody put up saying the south side of Chicago because apparently the hood don't play or something. So interesting enough, some urban areas didn't have any of these Pokemon in it, and so by not including certain types of populations, it could potentially increase like a health disparity. We actually just wrote a paper with one of my colleagues from the mHealth Summer Institute about smartphone watches, and it's and using sensors to predict or to pick up some kind of biometrics. And on people's, if you have a darker skin color, it actually, the signal is different than somebody who has a lighter skin color. And so if we're not, developing these technologies with individuals of all different types of populations, we could be missing out on some of these really strong health disparities, such as that 32-year life expectancy that people with serious mental illness have. All right, so user-centered design. I hope everyone can see this. Actually, just going to walk us through it. So with user-centered design, we have problem definition. And so let's say here in the room, we're going to come up with the problem for the community. And the community will say is the south side of Chicago. Does anyone know anything about the south side of Chicago? Okay, one person. Okay, so you're going to be our expert in the south side of Chicago, which is great. So problem definition is really made up of stakeholders and researchers, and so maybe not individuals living in that community who can tell us the important context that people live in. Study design, that would be this room as well. Needs development, we can go into the south side of Chicago and tell them what their needs are. They may be very different than the actual needs of the individuals living there. Data collection, of course we're going to collect data. Of course we're going to collect data from that population. Data analysis, that's us. Results and dissemination, that's mainly us. And so what we're really leaving out here with this user-centered design is we're leaving out the community. And so when we're working with certain populations who may have a mistrust in research, and that could be because of some historical context, it's really important to include those individuals when we're designing these products to promote acceptability of these products. And so we're doing a study now and we're interviewing 40 people with a lived experience of serious mental illness, and we're asking them about passive monitoring on their phones. And so these individuals, through 18 to I think like 70 years old, they're reporting to us, which is really interesting, that the older people in that cohort are saying that I don't want passive monitoring on my phone. I don't want people to know everything that I'm doing. The younger cohort is like, no, that's fine. I'm cool with that. Just let me know and collect all the data you want. Any ideas why potentially the older cohort would have these certain thoughts? Now remember, these are people with a lived experience of a serious mental illness. And so their experience with this could go back to the 1950s or 1960s. Any thoughts?
Well, so you have general medical mistrust and scientific mistrust.
Mm-hmm.
Perhaps lived experience, and maybe people have experienced an iatrogenic or negative impact of some kind of monitoring, whether technological or not.
Mm-hmm.
If younger people haven't had a bad experience, then they're going to be, and they're also younger people are very accustomed to being in public
Mm-hmm.
social media and having data publicly available and
Mm-hmm.
monitoring, and probably haven't experienced significant negative impacts of people like us monitoring them,
Mm-hmm.
maybe in social contexts of like relational stuff of people they know on social media, but kind of that anonymity, the perceived anonymity.
And that's
in the big data world.
And that's great, and that's exactly what we were thinking as well. And so these older generations, they have experience with the institutionalization where people were locked to the walls, they were chained to the walls or locked in rooms. There was some experimentation going on in this population, and so there's a strong distrust, like we're finding among this older population. Well, again, the younger population is more like, this is fine. They haven't experienced these types of effects, which is interesting. So let's say we're developing something for older adults with serious mental illness, and I include passive monitoring on the phone, and I can't force them to use it. And so these are important things to think about when working with these vulnerable populations, and of course knowing their history as well. Again, with these groups too, there's low research participation and insufficient uptake of research findings. And so millions of dollars have been spent on trying to address this early mortality gap among people with serious mental illness, probably even billions. There's been national initiatives, there's been efforts, and they've developed some amazing programs that are out there related to teaching people how to self-manage their mental health and physical health and diet and exercise. Great programs, but people aren't using them. And so to get people to actually uptake these programs, incorporating them into the development of these programs is really important to promote acceptability. So just another way.
So Karen,
yeah.
The 40 individuals you talked about,
Mm-hmm.
in terms of how you frame serious mental illness, is there different types of mental illness these individuals are experiencing, and based on the conditions of these mental illness,
Mm-hmm.
would that inform how you engage with them?
That's interesting, and this was a qualitative study, and these are preliminary findings, and I think that you just helped me delineate a mixed methods project where we can look at the different diagnoses and see if there's kind of differences between those. Because if somebody has paranoia, they may have less, interest in something with passive monitoring.
Right.
So as I write that up, thank you.
Do you know their treatment status?
Everyone is in treatment.
Okay.
Mhm.
Medication and therapy? Do you know if they're clinically stable?
Yeah, everyone would be completely stable, and I didn't know the treatment status. I know that everyone is in treatment. I don't know if they're using medication and therapy.
Mm-hmm.
And do you think that that would be something that...
I mean, in thinking how you would develop that more,
Yeah.
So you're sorting by diagnosis, but I think that what's pretty exciting about applying mHealth to mobile health is that there's such wide variation in the states and emotions of our users.
Right.
And we know very, very little about, whether they're clinically stable, asymptomatic, higher functioning, coping versus, and it's going to affect the age effect as well, right?
Right.
So, we know that, younger people with earlier onset bipolar or psychosis are going to have much more severe symptoms and potentially more frequent cycling, right? Compared to some of our older patients.
Right.
So, I mean, I think there's a lot there. And it might just be that as you play with your mixed methods that you begin to sort of tease out that maybe you couldn't figure it all out, but you're pioneering a method to think about some of the nuances among thinking about our end users who do have SMI. Does that make sense?
Yeah, that makes so much sense, and I'm going to reach out to the both of you as I write that up, if that's okay.
Yeah, it's like icing on the cake for your next grant.
Yeah.
Right?
Yeah.
You're on the K, you're peppering it all these ideas in. But it might be that in the future you'll have some preliminary data to further develop our methods on how to think about, patient-level characteristics in that interface. Right?
Yeah, and I think too that, I'll get into this, but even when I co-design these apps with people who have lived experience of a serious mental illness, and they're sitting at the table with me making decisions with me, and I wonder what, to advance the science of community engagement with digital health, and I wonder what that looks like as well. And so maybe there are some of these characteristics of individuals that that could, facilitate that equal partnership process, if that makes sense. So that's great.
And there's support systems. So you're probably working with more high functioning survivors.
And they're generally older too.
So I think the other thing that's really important is thinking about the role of the caregiver. We always think about it as in pediatrics, but oftentimes with our adults and our older adults, there are a primary caregiver, particularly for those with SMI, that are really influential, but sort of understudied.
Oh, that's interesting.
Caregivers and also potential partners.
Partners.
Yeah.
That's right. That's right. And I think that comes from the times when, like in surgery you do a med consent and they sign. Do you know what I mean?
Yeah.
But at least in mental health we know that there's a lot of our patients turn or have other people that are making decisions or support or shaping.
Yeah, and it would be interesting to look at the team that I work with, which I'll talk about in a little bit, to look at those social supports, because just anecdotally, everyone I work with, super high functioning, and they have a lot of social supports in place, and they're all older too.
Oh, you have your phone, you're checking your phone, that kind of stuff.
Yeah, and they co-present with me at places all the time, and it's just a phenomenal way to disseminate research, but advancing that science of what it looks like to engage with that community would be really interesting. Okay, we should definitely talk about that further. That's really helpful. Thank you. So I wanted to talk about how community engagement is some similarities to marketing science as well. So interesting enough, marketing science is they incorporate the end users in these actual products, just like how we do in community engaged research. And we know when we do that, that it shows higher level engagement with these products that we have. There's also motivation to help others, and then it's actually interesting enough, they recruit other individuals into the community. And so, in addition to developing digital health technologies with people with a lived experience, we're also training them to be researchers as well. And we're looking at ways to how they can assist us with recruitment using some of these same type of methodologies. So here's the model of reciprocal accountability, which our team developed. And this model really shows, what if you include a peer support specialist, so an intervention with a lived experience, and a consumer or a patient as well. So how does that actually increase digital health engagement? What is behind that? And so this is a very egalitarian relationship where there's autonomy, flexible expectations, shared lived experience, and bonding, and all of these influence digital health engagement. So David Moore developed the model of supportive accountability, and so that's where you're working in an organization, and there's a clinician, and they're encouraging a patient to use a mobile health application. And so in this sense, it's like there's a certain level of accountability that the doctor told you need to do this, and so the patient responds, okay, I'll do this, because there's a level of superiority and reciprocity within that as well. So that's supportive accountability, and reciprocal is more of the egalitarian type of approach. So what we did was we wanted to see what was out there in digital peer support. So we completed a systematic review of all the digital peer support interventions in the world. We found that there's 24 of them that are out there published on, and the technology platforms that people are using, smartphone apps, social media, websites, and listservs. And this is specific for mental health as well. Interesting enough, the studies were feasible, acceptable, and we say preliminary effectiveness because the sample sizes were pretty small. This is a really early stage research as we're developing this and moving it forward. But we saw that these digital peer support interventions, they increased participants' functioning, reduced symptoms, and improved program utilization. So really engagement in this. And I think one of the most exciting outcomes was that we looked at how these digital support interventions were developed. And 53% of them, so 12 or so, reported how they actually developed this smartphone intervention, Facebook intervention, website intervention. And we found that the ones that include user-centered design, they had okay levels of engagement. The ones that just included community engagement, still okay, modest levels of engagement. But the ones that include user-centered design and a really active method of community engagement, they had the best levels of engagement in the smartphone application, which is really exciting, and this is under review right now. So if we combine both of these approaches, so on the top is community-based participatory research, which is a very active level of community engagement where you work with the community to define the problem. People sit on your research teams with you, they're on the calls with you, they're making decisions with you. It really enhances user-centered design. So the combination of these two approaches, we think that we can really advance the field to really develop interventions where the people will be very willing for uptake. So here's a case study about the work that we've been doing, and this is PeerTECH right at the bottom, that's what we call it. And so this really developed out of, again, this early mortality that people have been experiencing. It's been hundreds of years now we've known about this. Millions of dollars spent, and the actual mortality gap, it's actually getting larger, meaning that people are dying younger, despite all of the work that we've been doing. And this slide is just related to these health behaviors that we've been working towards addressing with self-management interventions. So what we did was we did a systematic review. We're like, all right, well, what's out there? People are dying young, even younger than before, who have a lived experience. So what's out there that addresses mental health and physical health at the same time? So we found a bunch of different interventions. And we're like, okay, so there's interventions out there, but what about implementation? So we looked at some implementation barriers and facilitators. So some of these interventions are 2 years long. Could you imagine going to a place for 2 years that maybe is across town and you don't have a car, or maybe you're sitting in LA traffic, which I just experienced yesterday? I'd never want to experience again.
What are you talking about? What traffic? We have fires. No traffic.
There's no traffic in New
Road
Hampshire. Anyway, it's really costly, and they're delivered by like PhD level individuals who, it costs a little bit more to deliver interventions doing that. So we looked at some facilitators. Like, how are these interventions getting out there? Well, peer support specialist was one way to facilitate, and also technology. So I approached Dartmouth 3 years ago, and I'm like, well, how about we combine the two? And they're like, that sounds like a wild idea. I like wild ideas. Let's do it. I'm like, all right, cool. So what we did was we took an evidence-based practice called Integrated Illness Management Recovery. This original one, that's over here, it was really 200 pages. It was literally like the 2 weeks into my postdoc. They're like, translate this onto a smartphone app. And I'm like, what? But I stayed on, anyway. But it was 200 pages. It was that big. And so what we did with that intervention, we decided to use that one because it had real-world effectiveness. It's delivered over 12 months by a master's level clinician, augmented with a nurse, and it teaches people how to manage their mental health and physical health. And it has shown in 2 randomized control trials that it decreases psychiatric hospitalization, it increases people's ability to manage mental health and physical health simultaneously. Great intervention, nobody's using it. So let's adapt this so it could be peer-delivered and technology supported. So here we used an adaptive, just check the time, adaptive systems engineering approach, where this is really related to the usability studies that we did. And on the left-hand side, we have the requirements analysis. We're like, all right, well, what do we need for this particular population? So we did a review. We found that on the left-hand side, we have the identified needs of the individuals, and on the right, we have specific design features that we used. Won't go through all of these, but the first one is in real-world environments, older adults commonly present with multi-morbidity. So there's going to be COPD, diabetes, cardiovascular disease. It's not just going to be diabetes. And so we need capacity to address these types of things. And then, I'll read the next one too. Patients adopt and engage in health technology more if a human being is attached to that. And that's known. And so we really wanted access to live and automated self-management support as well. So the next thing we did, we selected the platform. We decided developing our own app would be very expensive, and that's really not our area of expertise. And so we purchased a platform that we could put on our own intervention content. And we actually changed this later on too. Like we actually aren't using that platform anymore. We've developed our own, but this was a while ago. And so again, like third day of my postdoc, I'm making wireframes of this 200-page intervention manual. So has anyone done wireframes in here before? Okay. So imagine, so a wireframe is when you open the app, where is it going to go, and what's the next picture going to be? So then it creates a picture over here, and then if you press a button, it goes here and here. So basically, imagine this whole wall covered with these little tiny pictures and a navigation tool. And so day 3 of the postdoc, I stayed on for some reason, and this process took a long time. I'm just joking, but interesting enough, the architecture for people with a lived experience of serious mental illness, they have there's potential for mild cognitive impairment as well, and so the design features have to be specific for them. So if we think about navigation algorithms for this group, we only have I think it's it only goes forward once and then it goes back, because if it keeps going forward, that could be confusing to an individual. And we also added in reinforcement as well. So if people who may have some memory deficits, we want to reinforce certain things over time to promote learning and mastery throughout the process. And we have a cool paper we wrote on that I could share with you if interested. So first we did this think aloud and verbal probing approach. So here I sit with my friend again. I hand you this app, and as you go through, here I'm going to stand up again. I'm sorry. So as you
I'll play along.
Okay, yeah, thank you. You're so happy to be here.
Yeah.
So this approach is that my colleague here is going to open up the app and is going to talk me through what he is thinking. I can't open the app. The password doesn't work. And I'm going to prompt you like, oh, put in your password. And so this is the process. 1 hour, really awkward, right? But we did find some changes that we would make based on your feedback, and we thank you for that. And so some of the
I just lost something. So
yeah.
Did you have a baseline focus group figuring out the values, the preferences before you went to the wireframe?
That would have been a great idea.
Oh.
I'll get to that because I'm kind of telling you my journey of decisions I should have made beforehand. Yes, and I'll tell you when I went to the MHealth Summer Institute, you'll see a big change in all of my processes here.
So the before and after.
Yeah. So there's no focus group. I just took it and translated it. Didn't work, but you'll see soon. So we got some good quotes from that and did make modification. So the nice thing about having multiple size text is that if you wear glasses and you're crying and you want some support, you can access the app, which is very cool. So great timing. So I take this app that we've developed using this, usability testing, clinical environment, and I brought it to a group of peer support specialists, older peer support specialists who there has been a history with the medical community and the research community that traditionally have rejected researchers. And they were about to reject me as well, because when I approached them after this app that we've created, without their input at all, they were like, get out of here, what are you thinking? And I'm like, I'm just a postdoc, it was really a medical model approach, and so we were trying to address early mortality using biological indicators of data. The language in it was using terms like patient, and we don't use terms like that. We use people with a lived experience of a serious mental illness. And so the nothing about us without us is the historical movement that has happened among the disability rights community where basically what it says is that, we don't want you developing programs and services for us without our input into that. So I'm so thankful that they said, okay, I see some potential in this. We're going to work together over the next 2-3 years and really learn about how to create something with a highly vulnerable group of individuals and change the language, change the structure. So this is what we developed. I'm so thankful they allowed me back into the room after I met with them. I wish I'd would have recorded that because the first meeting with peer support specialists, because they were like, no lady. Anyway, so this is what we've developed, and you could see this in JMR as well. So throughout the process of the next 2 to 3 years, really developing this app, we developed this entire framework of community engaged research where I have a peer research support team, and they provide feed-forward expertise. And the core investigator team, that's really me, providing the scientific methods, scientific evidence and new methods to create this full partnership where now we work together to plan our studies and intervention development, developing research questions, identifying outcomes, and then implementation considerations. And when we conduct the studies, they help with recruitment. They also help with retention of keeping people actually in our studies. And then we have some studies that they're actually providing the intervention and helping us develop the intervention guide. For dissemination, we do social media, blog posts, newsletters, presentations. Me and my colleague on Tuesday, we're presenting at Harvard University, which is really exciting, to 300 psychiatrists. And they really help develop relationships as well, because I couldn't really have access to that community without developing relationships with the individuals. So together, the line of research that we have been going through, which now we have National Institutes of Mental Health funding, we actually have the CORI funding, and we have NARCED funding as well. And so it's really exciting because people are really on board to this process and what we're doing. So together, we did a national survey of peer support specialists to find out, what is their ownership and use of technology. We weren't surprised, but we had to prove it to the scientific community or suggest it, that 95% of people who are peer support specialists, who are the interventionists, they own apps. and they're willing to use smartphones to promote health behavior change. And 83% of them are willing to text message back and forth. And so we have some evidence of in one of our intervention studies where people text message peer support back and forth. So while people are out in the community, not in maybe a hospital environment, they could receive the support they need. Here we did a study on the unmet needs of people with serious mental illness, and this has really guided the content in our mobile health application. So we have data from 267 peer support specialists, and we said, what is the top 5 unmet needs among people with a lived experience? The first one that they said overwhelmingly was loneliness. Loneliness needs to be addressed. Second one, social isolation. The third one was this idea of mental health and physical health as well. We need to address the self-management for that. And with those same 40 folks I was telling you about earlier, we asked them, well, why do people with a lived experience die earlier? And they said health behaviors overwhelmingly, and they also mentioned loneliness too, which is really exciting for us because we think that peers can deliver this intervention and really address loneliness as well. And we did some implementation stuff together. This is under review. That they want peer support to be a part of mobile health interventions. And then there was this thought too that mHealth interventions could actually promote social isolation for folks as well. So if people, they really want these applications to be really connected with health services, not just used out there.
So the 267 from 38 states.
Yeah.
How many declined? So how many folks did you reach out to, and what is the 267 representing? Out of how many folks?
Sure. So we used an email listserv which has 10,000 certified peer specialists. We did not offer an incentive for the individuals, and that data collection took place over about 4 months. So I guess it's consistent with other national representative samples of peer support specialists.
Gotcha.
And I could send you too, the actual demographics of the data as well. So let me go. So as we develop the mobile health application, we have I'll go through it and what everything includes. And so I included. So at first I was like, oh, we'll have peers add videos about self-management, their own personal self-management. And so I wrote them scripts. I'm like, here's a script of your recovery story. And they're like, so the 4 mHealth Summer Institute. And you can't script someone's recovery story. Anyway, so if I don't know if we have audio, we didn't test it, but we'll check it out. I don't know if we have audio, we didn't test it, but we'll. Oh, I don't know if it'll work on this because I might. I'll try. But this is Mitch telling his recovery story. Yeah, it might not work on this, unfortunately.
For me,
nope.
Yeah,
Sorry about that. But anyway, just showing you my learning process throughout this. And Mitch is telling his own personal recovery story about how sleep is very important to him, and how sleep could really exacerbate mental health and physical health symptoms that he experiences. So here's what we developed. We created this PeerTECH program that has 10 different modules that people go through. And the modules are related to teaching people about the brain and body, what is recovery and how does that impact health, practical facts about physical and mental health, how to live a healthy lifestyle, using medications effectively, building relationships. And in that as well, we don't want to just increase social support for individuals, because this is about mental health and physical health self-management. We're actually going to train the peer support specialists in an upcoming study how to provide acceptance and commitment therapy, because we think if we can help people restructure how they interact in their environment, that may impact loneliness. And also there's videos on there about managing stress. We have a lot of mindfulness videos on the app. And how to stay well. This is really the relapse prevention plan, so the wellness plan that people have. And then getting what you need from the healthcare system. So how do you advocate for yourself in these environments? The structure is they go through the goals of the classes, there's home practice, there's lived experience of class content. So we don't have something where people are just I don't know if you've seen those interventions where you have to sit together and you actually just read off of it just to ensure that there's fidelity. Well, peer support specialists really rejected that idea, and they said, well, I have my own expertise, my own lived experience that I want to share. And so we have prompts for them to share their lived experience after they read off some of these content on the smartphone app. There's mutuality and co-learning, so people are actually learning together. Yep.
I just had a question. I wonder, are there any adaptations that account for changes across the lifespan? So in some of the content in the previous slide, I just wondered, because there's huge differences between 28 and 72, and so,
oh yeah,
so how do you target, certain age range, age groups?
Sure, that's great. So the individuals I work with, they have multimorbidity, so they'll have multiple chronic health conditions. So with that, the content is actually geared towards that. So that brings me to the next slide. This is great. I love how you guys are leading into this. I appreciate it. So I think this will answer your question.
Yep.
So here's Joe right here, hypothetically. Joe can show up with, he's a patient, maybe has a lived experience of schizophrenia, COPD, diabetes, and cardiovascular disease. Let's say there could be another individual who could be like Steve. He could have COPD and schizophrenia, and we have the app personalized for them and their experience. And so that's really the adaptations we made for older adults, this multimorbidity factor. So I'll walk through the program, and just let me know if you know the question. So here's Joe, lived experience of schizophrenia and COPD and cardiovascular disease. Joe is working with the peer, Sally, and they're working one-on-one. And they're using the smartphone application and going through that together, because there's a library in there where we can sit together and read through some of the content together. We can watch videos together. And then there's a prompt for us to share our own lived experience about how we handle sleep, we'll say, for example, or stress. When Joe and Sally aren't together, they text message back and forth, and we use a very naturalistic environment. We don't prescribe text. We don't use AI or natural language processing to speak with individuals because we're hearing they want a live person on the other end of it. And they provide peer support while people are out there in the community at least 3 times during the week before that they meet, in between when they meet. And here we saw that we did a study, and we saw that they were providing peer support through text, which was really exciting. And we saw that as people were actually text messaging, we saw more engagement in the app. So people were checking out the library or watching videos. Also in the app, we have a wellness plan, which is a psychiatric relapse prevention plan. So people can write in there what their goals if they're not feeling well. They could just look there and know this is the number one thing I have to do. And they could share that if they wanted to with other individuals. We also have personalized goals in there. So we don't tell them, like I told you before, if I tell you guys to use an app, will you? It's like, no, it doesn't work that way. So so there we have their own personalized goals. And so we're seeing that a lot of people, their goals, it's around social support, that they want more social support and more community around them. And we think if you address those goals, that we can impact this psychiatric and medical self-management. So it's more of a proximal goal, and to impact that distal goal of self-management and early mortality. Yeah, that's all. And then here's the dashboard where we monitor everything to make sure that there's no suicidality, and if there is, we have, of course, a protocol in place. So we did.
So just going back to the question about tailoring it based on the age of the person. So, for example, each of the core components, for example, managing stress, personalized plan, is the language identical for a 20-year-old versus a 50-year-old?
Yeah, yes, now we have it, that it is identical language. Okay. And that could be something that I wonder in future studies if that's something that we have to address. What have you guys found?
I think that for relatability, particularly I've worked with TAE and that population, transition age youth, and I find that there's just no relatability to something, or the experiences that someone who's had SMI longer might have. So I think that's a huge component of engagement is relatability.
Okay. Yeah, that makes sense.
In terms of the language,
That makes a lot of sense, and we've worked with people age 45 years and older.
Oh, yeah.
And so we're getting that multi-morbidity.
Right. But
so
I imagine you want to engage. This is a great program for the younger. The
yeah.
younger you get somebody involved in this kind of an activity, the better outcome.
Yeah.
Then so I'd rather attract an 18 to 25-year-old for this. Who's way more savvy, and more likely to engage with this type of technology than trying to go through all the hurdles with somebody who's 55.
Yeah, and that's great, because that's neat you bring that up too. So NIMH said, well, why is this just for older adults?
Yeah.
My prior research has been just with older adults. So we said 18 and older in the K Award. And so I think when we look at that qualitative data closely too, we can look at it by age range too, and I wonder if we're going to see some of that relatability.
Yep.
And so for the K Award, we have this qualitative study, and then we're doing a 1-month field usability test too. And so maybe I could even incorporate some younger individuals in that who have multi-morbidity. I mean, it's still going to be there, and then ask these questions about relatability. Cool.
Right. And it might be that that you have several RO1s.
Ooh, really?
Do you know what I mean? That as you explore your data, you're going to be stratifying your data by these different age groups.
Yeah.
And each of them could be preliminary data that supports this focused R1 or this R1 or this R1.
Oh, really?
Mm-hmm.
Okay.
So just think about that, because I think you're getting a lot of good ideas.
Yeah.
And you've got a lot of breadth in your sample, and I think that as you stratify, by the and you might not have a very big sample size, but it's better than anybody else.
Yep.
Right.
Okay.
And so that could be then preliminary data if you stratify just by the TAE. Is there something different compared to your olders?
Yeah,
I didn't know that.
More influenced by social networks, and so you may want to even adapt content.
And are there different mechanisms, right?
Right.
When you look at the users, are there certain things that our older group understands better, but our young, there might be a lot of variation in engagement by the type of component.
Yeah, that's interesting.
So just, it might be then that you develop a strategic plan for a series of RO1s.
That sounds like that's what I need to do, and so I'm hoping we can continue our conversations, because this is helpful.
That I think she's responding
to the breadth of everything that I'm doing.
And I think in terms of the certified trained specialist you referred to, so we have quite a bit of coaches and field staff from our adolescent medicine trials network. So I think one of the things they learn is the initial rapport building with your participant is really important.
Yeah.
So thinking about, so I don't know the answer to this, but thinking about how you would kind of match, the peer support specialist that could be, enhancing or optimizing potential relatability with an older person versus younger person, and then also the gender difference between the specialist and the participant. And those are all, could impact engagement and relatability.
That's great.
Effectiveness.
Because we have some stuff on that already related to if someone a peer has diabetes and an individual has diabetes, then that's kind of where we encourage those interactions, and so I guess that's something probably to explore too. I think we have like one sentence in one of our articles, but it could be actually a whole line of research looking about how do you match individuals, and matching a community health worker versus a peer support specialist is probably very different as well, because there may be no lived experience in that. So that's cool.
You didn't mention this, but the assumption is everything's in English.
Yes.
Only.
Yes.
Yeah, I was thinking.
So let's just put that on your
RO1
strategic plan.
It's interesting writing the K. I have like the 3-year plan. It's a 4-year K, and 1 RO1 after that. But
so that might be your first. But I think that you're opening. You're opening up a lot of potential here to go in a lot of different directions.
That's really helpful to hear. Because thinking beyond the K1 award, which I think I'm like 5 months into it. So thinking beyond it is really important. So I'm hoping if it's okay, like, to keep these conversations going. Like, I need, assistance moving forward in the future. You know what I mean? Cool. Thank you. Let's see, what's the time? Since there's only 5 minutes, real quick, we did a pre-post study, 10 people with this program, and we found increases in hope, quality of life, recovery, empowerment, medical self-management, and statistically significant impact on psychiatric self-management, just with a sample of 10 people. And then looking at the original RCTs, we had similar findings, which is pretty cool. And the KO1 is helping us do this with a larger population as well. So some of the benefits for us, the content, really adapt it based on, including service users as equal participants. We've had amazing recruitment and enrollment, and we think there's a higher potential for uptake in the real world. All of the scientific research suggests if you use these approaches that it will help out in the future. Empowerment of community partners has been amazing to watch. And then co-learning with partners too. They bring new ideas and insights to me all the time, and I'm like, well, let's figure out how we can examine that together. Because even the idea of loneliness was their idea bringing to me. I'm like, all right, let's apply scientific methods to this. Here's Rob, one of my colleagues. We're presenting at Harvard next week, and says, working as part of this project was a new experience for me. I never knew if I was being directed by the Dartmouth folks or if I was directing them. This is the true definition of co-learning, trust, and partnership. So Rob's awesome. We publish together all the time. This is in the American Journal of Geriatric Psychiatry. And so remember I showed you that thing about the usability studies early on? So we wrote one, and we said this idea of, incorporating co-production of research or co-design with usability studies as well. We actually engaged some disability rights advocates who are pretty well known throughout the world, like Pat Deegan and Dan Fisher, and we promoted this idea of how do you enhance digital mental health engagement using recovery standards, which is the whole philosophy of services delivery. And we reiterated people with a lived experience of recovery should participate as equal partners. We also suggested a framework that allows service users to assess the effectiveness of digital interventions. And we want people with a lived experience on these national boards that are representative expert groups. And exciting enough, Rob and I just found out the other day, we were both invited to be part of this expert group smartphone app development panel for the American Psychiatric Association. So we're headed down to Washington, D.C. To talk to them about recovery and incorporating that into evaluation standards, which is super exciting. Some neat opportunities, probably familiar with them. Of course, smartphones, of course, texting, virtual worlds, and peer support. Peer support is well known to really promote reduce hospitalizations, decrease psychiatric distress. It's an amazing service that augments traditional treatment that you can receive in the community. And there's some exciting work going on in avatars now where if you think about if you have an individual on the other end of an app that you want to talk to, it could actually be, an avatar. And so you can, let's say the peer support specialist isn't feeling well that day, we can replace them with somebody else. So early research that's being conducted at Dartmouth. And this is our first, we developed this co-design training. So yeah, I could talk about this, but how do you train people with a lived experience how to work with scientists? So this is our first training that we went through in Kentucky and Tennessee. These are all peer support specialists. And everyone went through the ethics training, the IRB training, the city one that we all do and love so much. Well, it's also loved by peer support specialists as well. And so we have a paper that's under review now related to the cognitive effort involved in completing that, especially for community partners. Super exciting. And this came out today, is the Community Engagement, a starter pack for scientists. And so the co-design team is in there, and the PeerTECH team is in there as well. And we really are pushing this agenda of incorporating community-engaged research with usability studies as well. And this is the study coming up that we're doing. And there's only 2 minutes left, so I'll just thank everybody for having me here. Thank you. And I just want to say, too, so me and the co-design team, we developed a website, too. So we have blogs about our research that we're doing and upcoming presentations that we're doing, which is pretty fun. Are there any questions?
Sure, I'll throw out the first question. So, love your energy, really important work you're doing.
Oh, thank you.
This really exciting presentation. The thing we find with peer support, the challenge is always measuring fidelity that you mentioned at the beginning.
Yeah.
So I'd love to hear your thoughts on measuring it and how you've gone about that in your work.
Sure. So the KO1, we hypothesized that we would be able, we hypothesized that we could provide fidelity adherent peer services delivery with the smartphone application, and so the application would actually guide the delivery of that. We're also developing a peer support fidelity model where we're using a co-design research process and speaking with 50 leaders at each state to help us design that fidelity tool, which is really exciting and a lot of work. And in the KO1, we're actually comparing peer support to routine PeerTECH to routine peer support, and we're going to see which one actually impacts differences.
Interesting.
And finally, we're looking at popular peer support curriculum, and we're doing a content analysis of that. So, if anyone's interested in thinking about that stuff with us, let me know. We have a team of they're all like volunteers. They're just like me, passionate about the work we're doing all over the world, where we're really trying to advance peer support services. And so we have a really cool team that just really is working on this and moving the agenda forward. But happy to talk about that further.
Yeah, that's cool.
Yeah, thanks.
Thanks.
Any other questions? Hi.
So you mentioned the peer support folks you're working with are all volunteering, and do they have other sort of paraprofessional roles as peer supporters, in their institutions that they're receiving treatment at or working at, and how does that work?
Sure. My colleagues who are peer supporters who work with me on the research?
Yeah.
Sure. The folks. Sorry. Bothering you all presentation. Sorry. So there's actually state representatives. So there's a state consumer liaison or patient liaison in every single state. That generally will have a master's degree, super high level of functionality, and they work with us on projects, and we have access to everyone in all 50 states, and that's how we're going to be developing this fidelity tool. So generally people will either be working as peer support specialists in the community, or they'll be at the state level, and they're really helpful in helping us understand policy around peer support too, and making policy changes too. In fact, everybody's employed as peer support specialist and or at this policy level.
Okay, so they're being paid to do this work, and then with you, they're kind of extending that and volunteering in the work with you.
Yeah, and and by volunteering in that, they're written in on grants. So the group that I showed of those 5 or 6 folks, they're our grant partners on our PCORI grant.
So when you get funded, they get compensated.
Yes, yes. And for research team meetings, they get compensated at similar rates as other experts in the room too. And I don't know, we publish book chapters. There's some kind of intrinsic incentives too, and in that Nature article, there's a picture of everybody, and so they really want to do a documentary on the work that we're doing. So that's some of our colleagues in Kentucky, and so we worked, and they're being paid to think about these ideas too, because they're part of that grant that we're doing there. So that's how the compensation is. And we find too, even with the surveys, we don't offer incentives. People will just do them. I think it's because people are really passionate about the work that they're doing, and they really want to see change and really want to see services enhanced.
Great.
Cool. Thanks. Any other questions?
Are you able to share information on the Summer Institute you attended?
That
sounded really great.
Oh my God, you have to. It did you see everything changed at because of the Summer Institute? I should have put a timeline in there. Yeah, I would love to. Or Vivek, who was just here, he's the one who puts it on.
Okay, great.
Yeah.
But if you just Google mHealth Institute, mHealth Summer Institute, NIH mHealth Summer Institute.
I will, thank you.
Yeah, and UCLA's the site.
Fantastic.
Yeah.
And it was an amazing experience where, maybe I would have talked to patients before I would have embarked on all that beforehand.
Right. So Dr. Shetty's the site PI for that. It goes through OBSSR, and I'm one of the faculty. So.
Cool.
Good job.
Great.
Great. Well, thanks everyone for having me.
Thank you.
Appreciate it. Thank you. Thank you.